Hello, welcome to today's webinar. We still have a few people joining, so we will begin here shortly. In the meantime, please take a look at this interesting case while we wait. Okay, I think we are ready to go. My name is Erin Burnham, and I will be your host for today's webinar. Before I hand over to Mariana, who will be presenting today's topic, I'd like to go over a few housekeeping items with you. The webinar will be recorded, and we will share this with you via email shortly. While we love hearing from you, we have all been placed on mute for the duration of the webinar. We do, however, welcome your questions and comments, so please type these into the chat box and we'll do our best to get through as many as possible at the end. And finally, if you are having any technical issues, please just let us know via the chat box and we'll do our best to help. Thank you again for joining us for today's webinar. This is the second in our Equine Winter Webinar series. Today's topic is soft tissue injuries in the foot. Are there any clues on plain radiographs? After the webinar, we'll share more information about the last of our webinars to come. As I mentioned, Mariana will be delivering today's presentation. She is the head of equine with us here at VetCT. She has a wealth of experience in the field of diagnostic imaging, carrying a European diploma in diagnostic imaging, as well as being an RCVS specialist in large animal diagnostic imaging. In addition to teleradiology, Mariana also works in clinical practice as diagnostic imaging clinician. Her main interest is orthopedic MRI, but she enjoys all modalities. She has ridden horses from a young age and has competed at show jumping to a medium level. Okay, and now I will hand it over to Mariana to start today's presentation.
Good afternoon, everybody, or good morning, depending on where you are. And thank you, Erin, for your introduction. As Erin said, today we'll be discussing soft tissue injuries in the foot. And mainly, I would like to discuss with you what we may or may not see on plain radiograph that could give us a clue to what may be the final diagnosis. What I would like to talk about is trying to understand the radiographic anatomy of the foot and identify potentially clinically relevant pathology. And then we're going to go through the radiographic findings and how those may correlate with soft tissue pathology detected on MRI. First of all, which sort of changes can we expect to see on radiographs in association with soft tissue lesion? Well, soft tissue swelling, that's for sure, is one of them. But of course, we're talking about the foot today. So the degree of swelling that we may see associated with soft tissue lesion in the foot is very limited. But when we see it, it's usually significant. The other thing that we can see is remodeling at the area of attachment of the soft tissue onto the bone, so the enthesis. And to understand which structural needs might be affected, we of course need to have a good understanding and knowledge of anatomy and radiographic anatomy. We must remember that before a lesion is seen radiographically, there has to be a substantial change in bone density. And usually if less than 30% of mineral content, there is less than 30% of mineral content change, then this is not visible radiographically. The other thing to remember is that once the bone has resorbed or produced, then those changes may remain for long term, especially in the distal phalanx. I will now be tired to remind everybody that the best, if you acquire good images, that those are much easier to interpret, and therefore we will be much more likely to find significant findings, or perhaps not to miss subtle findings. So make sure you acquire good quality projection with good exposure, good foot preparation, and be careful to the little details when you judge the quality of your images. Clearly, these images are non-diagnostics. Before we go into discuss specific radiographic findings we may associate with soft tissue injury, I would like to discuss briefly the foot conformation. And that's because that is the first thing I look at when I look at foot radiographs, and also because there is a sort of idea that horses with long toe-low heel conformation may be predisposed to pathology of the deep flexor tendon. And these are example of three type of conformation. The first one on the left, this horse has a very long toe and very short heels and a negative palmar angle, so not a very desirable foot conformation. This in the middle has got flat solar angle, so the solar margin of the P3 is parallel to the sole, which is something that we see very commonly, especially in warm blood in Europe. And this is what is the foot supposed to be with a palmar angle, which is positive, about +4 degrees. So the toe is lower than the heels. And over the years, there have been a few papers that looked at the relationship between the palmar angle and the foot conformation and the presence of pathology on MRI. And this particular paper didn't look just specifically at that, but did look at the relationship between palmar angle and tendon lesion, and they did not find any. However, what they did find in this paper was that there is an association between the presence of deep flexor tendon pathology and thickening of the palmar compact bone of the navicular bone. A different paper looked at the foot conformation on MRI to try to understand if there was an association, again, between foot conformation and the presence of different type of foot lesions. And this was a large-scale study, about 200 horses were included, and they found that horses with a larger sole angle, so a large palmar angle, were less likely to have deep flexor tendon pathology or navicular bone lesion. But they didn't find a correlation the other way, so there wasn't a correlation between a low palmar angle and the presence of tendon lesions. And the height of the heels was significantly smaller in horses with deep flexor tendon injury. I think when we compare the two papers, we need to remember what we actually measure when we look at the palmar angle or the foot conformation on X-ray compared to MRI. So on X-ray, we look at the orientation of the solar margin of the P3 versus the horizontal, and which is normally between 2 and 8 degrees. While on MRI, we look at the angle between the flexor cortex of the P3 and the horizontal. So this angle is always larger than the one that we we look on X-rays. And maybe that has affected slightly the results of these two papers. So what have we learned from MRI over the years and how that may help us identify injuries in the soft tissues or using radiographs? Well, the first thing which is important is that we now know that multiple lesions usually coexist within the foot. And when we think about pathology of the polytrochlear apparatus, usually the ligaments of the navicular bone, the navicular bursa, and the navicular bone are affected at the same time. And we also know that pathology of the navicular bone in isolation is relatively rare. This has been evaluated in a recent paper. I mean, many papers are demonstrating the same thing. This is just the most recent one that looked at 550 warm blood horses, and they did see that in these horses, tendon lesion by themselves and navicular bone lesion by themselves were very rare. While in the majority of the horses, there were association between pathology of the bones, the navicular bone, and various soft tissues. So it sounds from these horses, from this study, that's looking at the navicular bone is a good start to understand if the horses may or may not have injury of the soft tissues. And in fact, when we look at this other paper, they identified that horses with higher navicular bone grades on radiographs were more likely to have a finer diagnosis of navicular bone disease, but also desmopathy of the collateral zygomedian and distal zygomedian implant ligament and deep girdle flexor tendinopathy on MRI. But of course, when we think about the navicular bone, not all the changes that we can see are necessarily associated with soft tissue injury. But this particular lesion, which are erosion of the palmar bone of the navicular bone, these are associated with tendon lesion. Of course, the erosion per se is already not a very good news for the horse and is clinically significant per se, but many of these horses will also have pathology of the deep girdle flexor tendon. And this is a skyline view where you can see the lesions in the flexor cortex and the sclerosis in the associated medulla. This is the corresponding MRI, and you can see how the lesion is much bigger on MRI, more obvious at least, and the reaction to the bone is quite substantial. And this is the same horse, a little bit more proximally at the level of the navicular bursa. The horse has a very small tendon lesion, but it has a substantial navicular bursitis with granuloma formation, which is likely secondary to both the tendon lesion and perhaps the navicular bone pathology too. Palmar compound bone erosion, deep erosion of the palmar compound bone were described first on MRI by Sherlock et al. Many years ago now. And in these horses, which were only 21 at the time, they found that 95% of horses had concomitant deep girdle flexor tendon pathology. I think what is interesting to take from this paper is that all these horses that underwent MRI with this erosion did not have radiological findings, radiological evidence of navicular bone pathology according to the referring vet. And the question is if that was perhaps missed or the images were not very good. But actually, they did go back to look at the radiographs of these horses, and even retrospectively, they could only see the lesion in 9 out of 16 cases. And that highlights the fact that these lesions are not always necessarily visible or easily visible on radiographs. What has been proposed since then is the acquisition of an additional view, an additional skyline with a shallower angle. So you acquire at the angle of 30 degrees rather than the usual 45. And that will skyline the distal aspect of the navicular bone and will help highlighting erosion that are at the distal end, distal portion of the navicular bone. And this is an example of a case that I've seen in the clinic years ago. And this horse had not a particularly exciting sagittal ridge in the 40 degrees angle down, but when the X-ray was retaken at 30 degrees angle down, then the erosion becomes clear. Thinking instead of the deep tibial flexor tendon, I think another clue potentially could be the presence of soft tissue mineralization. And in this particular case, this is a horse with severe bilateral forelimb lameness, blocked to the foot. Of course, we do have a nice lucency in the flexor cortex of the navicular bone, which per se is already highly suggestive of the deep tibial flexor tendon pathology, but the horse also has this mineralization within the soft tissue just proximal to the navicular bone in the location of the navicular bursa. And this is the MRI of this horse, where we can see that there is a tendon lesion. And we can see that when we go a bit more distally, that is the level of the navicular bursa, and we can see changes in the navicular bursa dorsal to the tendon. I can't see the mineralization within the bursa, but this is often difficult to see on MRI. But certainly we can see the changes in the tendon. And of course, when we go more distally, we will be seeing also the erosion of the flexor cortex that we already detected on MRI. Just remember that mineralization within the soft tissues can be seen also as an incidental findings in the equine tendon ligaments. This paper predominantly looked at changes within the pastern region, so not dislocation. Still remaining in the navicular bone, this subordinate fragment could be a significant finding because fragments are embedded in the impar ligament, and we know from histopathology that the presence of this subordinate fragment is associated with the presence of impar ligament dysmorphopathy seen on high field MRI and also on histopathology. So if we see a fragment, then we can conclude that it's likely that this horse will also have impar ligament dysmorphopathy. In regard to the impar ligament, this is another finding that we'd really like you to pay attention to, because it's something that is not very easy to see and in my experience often missed, and is the osseous resorption at the level of the flexor cortex of the distal phalanx. So this was first described by Yang et al. In 2012, and they looked at osseous defects that were larger than 2 millimeter on MRI. And these are seen radiographically as this lucency superimposed, well, in this particular case, superimposed to the DAP joint, but actually they are located in the flexor cortex. They found this lesion with the prevalence about 10% on MRI, and radiography had the low sensitivity, about 50%, but it had a very high specificity, which means that if you do see the lesion, that is a real lesion, and likely significant or significantly associated with impar ligament dysmorphopathy. And in fact, this lesion that they detect were located at the insertion of the impar ligament and deep tibial flexor tendon, and they found concurrent lesion in the deep tibial flexor tendon in 7 out of 8 cases. And on postmortem, they saw changes in both the tendon and ligament dorsal border. And this is an example of these lesions on MRI. And this horse also has a deep tibial flexor tendon lesion on the same side as the erosion of the flexor cortex. This is a 9-year-old thoroughbred gelding, which was lame after pulling the shoe. I think if you look carefully at these images, apart from the large synovial invagination on the distal border navicular bone, you can see bilaterally lucency, large lucency in the in the P3. They're in a slightly different position compared to the one that we saw in the paper just in the previous slide. That's related to the slightly different position of the foot when you take the dorsoproximal palmar distal oblique view. And to see better the flexor cortex, you'll need to flex the limb more, so position the navicular bone higher over the P2, so you can see better this area. This was completely overlooked imaging-wise, and it was not picked up on radiographs. And I think the reason is because the history. I mean, the pulling of the shoe was clearly a red herring, and the horse, and that had nothing to do with the actual lameness. And in fact, this horse had huge cystic lesion at the insertion of the impal ligament, which were the only abnormality that I could find, and therefore the cause for the lameness. I spent a lot of time looking at variation of the flexor surface after disappearance, trying to see if these lesions or these changes can be seen on the lateral medial view, because many times when you see a little looseness like the one we just discussed, it's quite nice to look at it in another view to make sure that it's real, that is not an artifact. But I find interpretation of the flexor cortex very difficult on the lateral medial view, and that's because of the variation of the flexor surface, which mainly relates to the presence of enthesiopathy of the deep flexor tendon insertion, which many horses have, and usually is not necessarily of clinical significance. So if you see this horse on the right, it had a much larger enthesiophyte insertion of deep flexor tendon compared to this one, and then on the left side, this one had a very flat flexor cortex. This is one of those that actually I was convinced that the lesion was present on the lateral medial view too. Of course, the lesion is pretty huge on the MRI. So that's maybe why it was visible. But this horse had absolutely no enthesiophyte at the insertion of deep flexor tendon, and we can clearly see this cystic lesion at the insertion of the impal ligament. And in this particular transverse images, you can also see the disruption of the impal ligament itself as it blends into the cystic lesion. Of course, this also has a large erosion of the flexor cortex of the navicular bone. Proximal border enthesiophyte, I find it considerably less exciting than the distal border fragments or enthesiophyte. And the reason is because these are very common, especially on the lateral side due to increased stress. And despite some horses with enthesiophyte do have collateral medial ligament pathology, I don't think that anybody has demonstrated an association between the two things. What is more exciting, but I've only seen twice in my career, is proximal border fragments. These are avulsion fragments. This was quite chronic, but these are probably more likely to be associated with collateral medial ligament pathology. I'll move away to the navicular bone and discuss a little bit about ossification of the ungular cartilages. A lot has been written in the recent year about the ungular cartilages and how the changes in opacity and thickness of the ungular cartilage is associated with the presence of sclerosis and bone edema on MRI. And this is an example of very thick ungular cartilages, biaxially and very ossified, and how they look on MRI with this increased signal intensity and stir, which is indicative of fluid and remodeling. But what was also found, it was a significant association between ossification of the collateral cartilage and collateral ligament desmopathy. And in this case, it was proposed that collateral ligament desmopathy was significantly higher in horses with potential significant ossification. And for potential significant ossification, it was considered an ossification that was grade 4 or 5, so above the proximal border of the navicular bone, if you look at it from a DP view. To be honest, I have seen horses with less severely ossified cartilage, but abnormal remodeled cartilage that did have collateral ligament desmopathy. And this is an example of a horse with bilateral lameness, which improved to abaxial block. This horse had extensive biaxial and bilateral ossification of the ungular cartilages. But if we look at the cartilages themselves in this particular horse, the cartilages are not sclerotic. They have a nice cortex and a nice cortical medulla demarcation. However, because they're so ossified, there still can be a predisposition to have injury of the collateral ligament, which this horse had, as you can see in these transverse views. What we do find in MRI also is that when these ungular cartilages are severely ossified, they usually extend dorsally, sort of hugging the insertion of the collateral ligament. And this you can see on both sides, which may predispose to the development of desmopathy. Another thing that we can see in association with ossification of the ungular cartilage is presence of collateral sesamoidean ligament desmopathy. And this is usually ipsilateral to the ossified abnormal cartilage and is much less talked about than the collateral ligaments, but I do see very often. And then we've got the injury of the ligaments of the ungular cartilage themselves, which often occur when the cartilage are markedly ossified. And most commonly, we see pathology of the chondrocoronal ligament, which is the ligament that connects the top of the cartilage with the dorsal aspect of the dorsal median lateral aspect of the middle phalanx, and injury of the chondrosomoidean ligament, which is this little ligament that connects the base of the cartilage with the navicular bone. I don't think we can see changes radiographically to suggest which of these ligaments might be affected. I mean, usually we don't, but because of the ossification of the ungular cartilage themselves, we should think that perhaps other ligamentous changes may be present and may contribute to the lameness. This is a horse where I actually did diagnose injury of the ligaments of the ungular cartilage by radiographs, which was then confirmed on MRI. And this is because of the this irregular periosteal reaction that was present on the distal aspect of the P1. And then if you go back to the Butler book, then you can see exactly which structure attaches in this location. And it happened to be a ligament of the ungular cartilage. And I thought it was very interesting that in this case, this horse did also have ossification of this cartilage, which was also sclerotic. And this is his MRI, which confirmed the sclerosis, the changes in signal intensity, not only in the cartilage, but also in the collateral sesamoidean ligament and chondrosesamoidean ligament. And this is the changes in the bone and ligament attachment on the P1 that we saw on X-ray. As you see, the changes in the bone are considerably less obvious on MRI than there are on X-ray. And that's why many times when I read MRI, I go back to X-ray to see if I can see this periosteal reaction a bit better. When we think about collateral ligaments, we also need to think about the collateral fossa. So, as we know, the collateral ligament will insert in the collateral fossa of the distal phalanx, and when they looked at radiographic abnormality in horses that had MRI evidence of collateral ligament-related osseous abnormality, this was only seen in about 10% of the horses. So the sensitivity of radiography to detect changes of the fossa are very limited. We can see antesiophytes sometimes, we can see osteocyst-like lesion, but the other changes like endosser reaction, I think are very difficult to see. And the reason why it's difficult to see is because depending on the view that you take and the quality of the image, the fossa may be more or less obvious and more difficult to evaluate. I also find that the fossa can look considerably different based on the type of horse that you look at. So if you have a big cob or draft horse, they will have a much more irregular fossa on MRI than a thoroughbred, and that may not necessarily be a significant finding. This is an example where I convinced myself that I could see radiographically that the fossa was irregular. This is the MRI, and we can see it on this side, the fossa is thicker, more irregular at the bone ligament interface compared to the smooth appearance of the other side. And then if you go back to radiographs, then you can see potentially that this fossa is a little bit irregular, perhaps the cortex is a little bit thicker. Of course, I don't think I would have made that call if I didn't have the MRI to support this hypothesis. This is an 11-year-old German warmblood, which was used for intermediate show jumping. And this horse went lame in the summer, and then lameness resolved in 15 days of rest, and then he competed fine. And then about 6 months later, he went acutely, severely lame, 4 out of 5. And the horse improved but remained lame, and that's when he went in for MRI. And if we look at the radiographs, and we look at the fossa in particular, I think there is a large lucency present into this lateral collateral fossa, which you can see also in the DP view. And in the oblique view, you can see that actually there are probably more than one cystic lesion present in this fossa. What is much less obvious, and I'm not sure I would have necessarily picked it up without knowing the MRI, is that there is another lucency on the other fossa, which is not visible in the other views. And this is the MRI of the same horse, where we can see that there is a fossa on the lateral side, sorry, a cyst on the lateral side in the collateral fossa, and a much smaller cyst on the medial side. And what happened to this horse is that he had a severe disruption, partial rupture, partial avulsion of the lateral collateral ligament. And I don't know the definite answer for these cases, but the cyst, it hasn't formed in 3 weeks. So presumably the cyst was present before, perhaps in this case had developed at the time of the initial lameness in the summer. And then what happened is because the area of attachment of the collateral ligament is disrupted, then it acutely avulse or partial rupture the collateral ligament, which was the cause for the lameness in this particular moment. This is the case that you had to look at while you're waiting for the start. This horse was a 14-year-old warmblood, and with chronic osteoarthritis of the disinterphalangeal joint, and then he had a firm, painful swelling on the dorsal medial aspect of the coronary band. Of course, this swelling was picked up clinically, so we just need to confirm its presence, and we can see it on the dorsal medial aspect. And the presence of this swelling in this particular location for me is highly indicative of severe collateral ligament injury. And This horse, in addition to the swelling, it also had some remodeling at the level of the dorsal aspect of the cortex, but it also had a well-defined cystic lesion at the level of the collateral fossa. So these usually are located in the palmar aspect of the fossa, the same way as the cyst in the distal phalanx are also located in the palmar aspect of the fossa, presumably by the way the fossa is loaded. That probably is the represent the area of stress where the bone reacts the most. I don't know the exact diagnosis of this horse because it did undergo MRI, but my diagnosis from the radiographs was a cystic lesion at the origin of the medial collateral ligament and presumably severe disruption of the collateral ligament, which could potentially be confirmed by ultrasound. This is a very similar case, which I don't have the radiographs for, but I have the MRI. And this is the location of the swelling, exactly the same location that we just seen, proximal to the coronary band, just also to the collateral ligament. And that's how the collateral ligament looks like, which is partially avulsed from its origin from the collateral fossa, and it's got severe changes in signal intensity, which are indicative of severe pathology. Last condition I want to talk to you about is the distal interphalangeal joint capsule. And that's another finding that often is misinterpreted or perhaps not necessarily ignored, but interpreted different than it should be. On radiographs, we often see osteoarthritis of the DAP joint, and then sometimes we see this reaction on the dorsal cortex of the P2. And sometimes that can be confused with remodeling of the origin of the collateral ligament. And sometimes that is the case. However, it should be confirmed by oblique views to exactly see where that new bone is located. But I think what gives it away in this particular case is that not only we have a periosteal reaction, but we also have an endosteal reaction in the sense that the dorsal cortex of the P2 is markedly thickened, and that is not normal and is not associated with collateral ligament pathology. When we do MRI in this case, we can see the thickening of the cortex. The dorsal cortex shouldn't be thicker than the palmar cortex in the P2. And we can also see a little bit of fluid on stir sequences. Of course, there is not very much effusion in this particular horse, but the pathology is not within the joint, is within the joint capsule attachment. And this is 15 years old warm blood. This had a recent onset of rifle lameness, which was variable in degrees, and some days was mild and some days became 4 out of 5. But had an average lameness of 2 out of 5 in a straight line. And you could palpate thickening of the distal interphalangeal joint capsule. The horse underwent MRI to see, what was going on. I think if we start from the radiographs, we can certainly see the soft tissue swelling on the dorsal aspect of dorsal to the P2, which is indicative of joint effusion. I mean, swelling of the DAP joint per se, I don't find it particularly exciting in radiographs because many horses have it independently of what the pathology is. But what I find it quite interesting is this very subtle periosteal reaction present on the dorsal aspect of the P2. And when we go into the MRI, we can see that there is a slight bone proliferation, but you understand how it's much more difficult to see on MRI than it is on radiographs. And that's because the slice thickness and the resolution of MRI is lower than radiographs. Sorry, the slice thickness is, we've got a slice thickness 5 millimeters sometimes. So then if you have a very small periosteal reaction, you can't see it because you just miss it. And then the resolution, so the distinction between different colors is lower on MRI than is an X-ray. And then in this horse, there was also extensive bone edema within the dorsal cortex of the P2, which made, to me, that's a very significant lesion. And potentially you can argue that we could have known all this just by spotting this little periosteal reaction on this lateral medial view. Of course, if your lateral medial view is oblique, you won't be able to see that. So as a take-home message, I think we need to remember that when we try to diagnose soft tissue injury based on radiographs, we need sometimes to look for very subtle changes. And of course, to do that, we'll need to have a high quality radiographs to make our job a little bit easier. Some changes are more relevant than others, so we can see radiographically. And for those, I will remind you of erosion of the flexor cortex and navicular bone, erosion of the flexor cortex of the distal phalanx, cyst at the insertion of the collateral ligament, for example. However, even if we spot some changes, they might be significant. There may be others that might be present and we don't know about, because there are many pathology usually coexist within the foot. Also, unfortunately, many horses have absolutely perfectly normal radiographs and severe soft tissue injury present. But for these cases, then advanced imaging will be needed for a diagnosis. So I have finished with my presentation, and I'm very happy to take any question that you might have.
Thank you, Mariana. We've had a few questions come in already. As a reminder, please enter your questions into the chat box and we'll get through as many as time allows. Okay, let's see. Our first one, do you have specific criteria to differentiate between the synovial fossa in the sagittal ridge of the navicular bone and cortical erosion?
I guess you mean that little lucency that is sometimes seen in normal horses as sort of half moon shaped lucency in the sagittal ridge. Well, the way I deal with that is that if the normal lucency is usually very well defined and there is no associated cortical thickening. And and usually if you have a very nicely positioned lateral medial view, you can see that little dip in the sagittal ridge in that view too. So if that lucency I see in the sagittal ridge is not well defined and is of the size that's not consistent with the normal lucency, and there is cortical thickening, which obviously often is present in association with erosion, then I'm quite happy this is abnormal. Also, the normal lucency you normally don't see in view other than the skyline and the lateral medial, as just said, while the erosion you will be able to see on you should be able to see on the dorsal proximal palmar distal oblique view, and often also on the DP view.
Thank you. For the changes at the site of flexor inserting to the P3, how to differentiate it from the changes caused by distal sesamoidean ligament lesion?
So the erosion of the flexor cortex, well, these are usually, when you look at MRI, those lucency are at the insertion of the impal ligament. However, the impal ligament and the deep flexor tendon are very close by. So it's quite difficult to know exactly which one is affected. And most of the time, as the paper suggested, they're both abnormal. So I'm not sure that it's super important to exactly determine which one is affected. But if you see it, I will think that is a significant finding and indicates at least impal ligament desmopathy and possibly also deep flexor tendon pathology.
Thank you. Next question. Do you always recommend MRI whenever you see ossification of the collateral cartilages?
I was no. Well, it depends how much money the horse have. If they can, yes. But I think it really depends on what do you, what you need to do with the horse. Because if the angular cartilages are, if the horse is lame and the only finding is angular cartilages and the angular cartilages are normally normal in the sense of ossified, but with a normal cortex and a normal spongosa, then I wouldn't think that those per se will be the cause of the problem. So we'll expect this horse will have a soft tissue injury, in which case I would quite like to have an MRI to see exactly which ligament it is. Because, for example, if your both angular cartilage are similarly affected, it's very difficult to know if it's the lateral or the medial collateral ligament that will be potentially abnormal, or the collateral medial ligament. If the angular cartilages are very ossified, but they're also increasing opacity and irregular, well, then it could be that the angular cartilage per se is also a cause for lameness. And yes, of course, the horse might also have collateral ligament pathology, which would be nice to know, but I think those per se could be a cause for lameness. So if you see that one cartilage is more ossified and more sclerotic than the other, then you can assume that that is the side that is overloading, and perhaps assume that is the side to treat, if it makes sense. But yeah, ideally I would have MRI everything, but of course we can't we?
Thank you. How do you find these collateral ligament injuries in the DIPJ or the PIPJ heel? Do they need repeat MRIs?
Oh, that's a very good question. So I think if you have a very severe lesion, they do get better on MRI when they get clinically better. How long you need to wait, that's a different question. I find sometimes when you see very subtle lesion in the collateral ligament, I find it quite frustrating because they tend to re-MRI the horse after 3 or 4 months, and then they look exactly the same. And then it's very difficult to know if if the horse is sound, if those needs a little bit more time to heal on MRI, but actually they have healed on clinically, so that should be fine. So I unless they are very severe lesion, like the one partial rupture, I don't necessarily re-scan them, and we go for the clinical sign. But as I said, sometimes we do, and they look the same for a long time, in my opinion.
Thank you. Do you acquire a 30 and 45-degree PPR PDI oblique in all foot series?
No, I don't, but I do when I find something that is really, I add it if it's odd. If I'm not convinced in the 45 degrees that is the flexor cortex is completely normal, or if I'm not convinced from the lateral medial view that the flexor cortex is not completely normal, I do acquire another view. It might be that a 30-degree view should be included in the pre-purchase series of the foot, so 2 views, just to make sure you do not miss that. But no, I do not do that routinely.
Thank you. Can the collateral injuries or lesions be visible on ultrasound?
Well, that's very dependent on how good you are on ultrasound and how big the lesion is. As everything, I think the last few lesions that we saw, the partial rupture with the swelling, I don't think you need an MRI to diagnose that. If you ultrasound it, you would see the lesion in the ligament, and you would see the periligamented tissue swelling very, very easily. Of course, what you won't see on ultrasound is how distally the lesion extend into the ligament. And I mean, depends on your expertise. You might not be able to determine exactly how severe the lesion is, but I think you will be able to see them. However, in the real world, the majority of the ligaments lesion, or at least the one I see on MRI, are much more subtle than those ones, and also mostly located at the distal insertion and the axial aspect of the ligaments, and those won't be able to be seen on ultrasound because of the hoof capture. You can't just image that part. So I would recommend to ultrasound the collateral ligament if you can before going into MRI to see if you see something. But if you don't see anything, that doesn't mean necessarily that the ligament it's normal.
Thank you. Do you think horses with DDFT and navicular erosion lesions have a good chance of long-term soundness?
No, that's my personal take. I mean, it really depends. I mean, the erosion of the navicular bone will not refill. So that is necrotic bone, and they will persist, and presumably the pain and the edema associated with this erosion will remain. A tendon lesion, some have more success than others, depends on what the horse is supposed to do. But I don't give a good prognosis. I give a poor prognosis for these horses with combined navicular bone and tendon lesion. Often you have adhesion formation, and even if you manage to keep the horse sound for a while, then often you have tearing of adhesion once the horse starts, a little bit more work again. So I think they're very, very frustrating for us treating them and for the owner actually dealing with the horse that goes being lame again, but maybe other people have different experience.
Thank you. Is there any relation between osteoarthritis and soft tissue injury?
Well, many horses have coexisted in a different pathology. Many horses will have osteoarthritis of the DOP joint and many other soft tissue injury. What causes what, I don't necessarily know. I think, osteoarthritis per se will probably see in about 70% of the horses that go on MRI, or at least in my population. And some of them have, or the majority of them have other lesions that to me are also contributing to lameness. You can argue that if you have moderate to severe collateral ligament pathology, that can create joint instability and perhaps predisposed to DOP joint, but I'm not sure I can find a complete relationship between those. In a sense, if the horse has got DOP joint pathology, I don't think I would predict any other soft tissue disease. Not
Thank
sure I've
you.
answered this question.
Is it possible to see the demopathy of the distal impaired ligament on low field MRI or only on high field?
Right, so the smother the impaired ligaments on low field MRI is a guess game, I guess. And the reason why is you can't quite see it very well, the impaired ligaments, because you only have one slide, if you're very lucky, two through the impaired ligament. So if the ligament is very massively affected, so it might increase in size, and sometimes when you have big fragments, you can see change in signal intensity within the ligament associated with the fragment, then yes, I can diagnose that. But the majority of the time I diagnose impaired ligament dysmorphopathy on low field MRI is because I see changes at the ligament insertion and origin, and therefore we sort of assume that the ligament is abnormal, and that we assume that because we know that those horses, when they go on post-mortem on histopathology, do actually have evidence of dysmorphopathy. So that's how I deal with it. So they're saying this, you can also argue then if you see a fragment to start with on X-ray, then perhaps you can make the same assumption, and the same if you see an erosion of the flexor cortex on X-ray, of the flexor cortex of the distal phalanx on X-ray, you can again assume the same as I would do on MRI, that the impaired ligament is abnormal.
Thank you. Medial lateral imbalance. Are you concerned about this, particularly at a vetting situation? and unilateral ossification of the collateral cartilage? Are they more prone to developing collateral ligament injury?
Medial lateral balance. I think it really depends a little bit of what horse I'm looking at. I mean, I don't really do pre-purchase other than pre-purchase X-ray, and I think sometimes you need to correlate how the X-ray looks and how the horse moves, and then the general appearance of the foot. Because if you have a bit of imbalance, mild imbalance, but the horse is a bit long in shoeing and needs to be trimmed, and that perhaps can be easily corrected, then I'm not particularly worried about. If it's a severe imbalance, which I don't think I see very often, then perhaps is a little bit of concern. But would I fail a horse for that? Probably not, unless there is any other things that concern me. That's all assumed that the horse is absolutely sound and performing fine. Unilateral ossification of the angular cartilage usually is a bit more significant than bilateral, biaxial, and that's because it means that there is asymmetric loading of the foot and therefore more stress on that particular side. And they did find that if you have very asymmetric angular cartilage ossification, that is a bit more of a concern than you have biaxial ossification. I think it also depends as I said, of the opacity itself of the cartilage. So if the cartilage is uniaxially ossified, usually you'll see there's also increase in opacity and sclerotic, which then confirm that that cartilage is abnormal and a potential is undergoing abnormal remodeling and therefore may become a problem or may already be a problem.
Thank you. I think we have time for one last question. CT and CECT is very useful for DDFT lesion, which has been confirmed on several papers. How about the sensitivity of CECT for other soft tissue injury in the foot?
Contrast and CT. Well, I think we need to, well, we're discussing about horses that are in general anesthesia, that you do fan beam CT and contrast enhance. I think when you do your good study, I think you will diagnose the same diseases that you will diagnose on MRI on CT. CT, contrast enhanced CT actually gives slightly different information compared to MRI in the sense that it will give you idea of the vascularization of the lesion and healing of the lesion a little bit more than MRI. So I grew up with MRI, so I do prefer and I'm much more comfortable with MRI, but I find that CT is equally useful for soft tissue injury in the foot if you use contrast and you do a good study.
Okay, thank you very much. Just to close, thank you again for Mariana for sharing your insight and expertise with us. And thank you to everyone who joined us for today's webinar. If you enjoyed today's presentation and would like more information about the last webinar in our Equine Winter Webinar series, please scan the QR code on the screen now. We will also share this information with you in the follow-up email. If you have any additional questions or would like further information, please get in touch with us using the contact information shown here or by taking a quick look at our website. Thanks again and enjoy the rest of your day.